Hello and welcome back to part 3 of 4 of the neurosensory clinical cases. Today we're going to be looking at 10 more cases from the neuro block of year 2. Some of the cases we're going to cover are foot drop, ALS, movement disorders such as Huntington's, Charcot-Marie Tooth disease, Guillain-Barre syndrome, motor neuron disease, stroke, ataxia, apraxia, multifocal neuronal neuropathy, and double vision. So let's get started with foot drop. So foot drop is a weakening of the muscle that allows for flexing of the ankle and toes. So the nerve that is involved here is the peroneal nerve. And a characteristic sign of a patient with foot drop is that they drag their foot whilst they walk. Okay, so it's a muscular weakness or paralysis. It's also sometimes called drop foot. It's a sign of an underlying problem rather than natural condition in itself. So in terms of the problems that could be arising, it could be muscular or nerve damage in the leg, or of course it could be as a result of a brain or spinal injury also. Usually this condition only does affect one foot, however both feet may be affected in some cases, but this really does depend on the cause. So in terms of causes, we can be looking at muscle weakness, peripheral nerve problems, or a brain and spinal cord disease. So brain and spinal cord disease are the easiest one to tackle, so stroke or cerebral palsy are the main two that are likely to cause foot drop. Muscle weakness, so this can be a gradual muscle weakness and it's only sometimes it may lead to foot drop, but it could. And a peripheral nerve problem, so this is when there's a compression of the nerve that controls the muscle that lifts the foot, so that would be the peroneal nerve, as we've previously said. Moving on, we look at amyotrophic lateral sclerosis, or ALS, which is a name given to a disease that's a type of motor neuron disease. It's a progressive neurological disease that causes dysfunction in the nerves that control our muscle movement. Lifespan is actually quite low for this disease. It's only around 3 to 5 years after the symptoms start to appear. So in terms of symptoms, we're thinking about fasciculations in the arm, muscle cramps, tight and stiff muscles, so spasticity, muscle weakness in the arm, legs, neck, and diaphragm, and also slurred and nasal speech. The symptoms of ALS can be subtle, however, and therefore sometimes they are overlooked until they develop and cause the patient to become obviously more weak. In terms of inheritance in this, around 5 to 10% of cases are genetic or familial. 90% however is sporadic. However, risk factors with regards to sporadic cases are age. So normally this is quite common to strike up between 55 and 75 years old. Men are slightly more likely to develop ALS than women. And also race and ethnicity can play a slight role, however that's not quite as prominent. In terms of treatment and management, there's no actually treatment for ALS, but medication, particularly physiotherapy and therapy, can really help patients suffering from this disease. Next, we look at movement disorders. So the one we're really exploring here is Huntington's disease. Parkinson's was covered in a much earlier video. So in terms of examples of hyperkinetic disorders, you need to know, and hypokinetic disorders. A hypokinetic disorder example would be Parkinson's, and then hyper, indicating too much movement, kinetic disorder would be Huntington's. So it used to be called Huntington's chorea. So chorea refers to a jerky or involuntary movement. Huntington's is an inherited disorder causing progressive damage to the basal ganglia and cerebral cortex. So it's to do with movement. Okay. Dystonia is slow movements which change your posture. Chorea is dance-like quicker movements, like jerks, as we previously said, and myoclonus, which is a quick jerk-like movement or a twitch. Focusing on the bottom half of the slide here, it affects neurons of the neostriatum, and it's caused by triplet expansions in the Huntington gene, which is on chromosome 4. It's inherited in an autosomal dominant manner, and therefore you've got a 50% chance of inheriting this condition from your parent if they're a sufferer. Normally the patient does deteriorate over a period of time, so 20 years is a typical course of deterioration. And the age of onset is truly affected by the expansion length. So remember how I said it's caused by a triplet expansion of chromosome 4 of the Huntington gene. It depends how much that gene has expanded more than what is considered normal in terms of what age the Huntington's onset is likely to be. Moving onwards, we have Charcot-Marie Tooth disease, which is a muscle wasting condition which affects both the motor and sensory nervous system, and it does not affect life expectancy. It causes weak lower leg muscles, which leads to frequent falls for the patient and also an impaired gait. It's a type of polyneuropathy. So what we mean there is it's a degeneration of peripheral nerves, more than one, that spreads to the center of the body. Okay. It can also be known in cases as hereditary motor and sensory neuropathy, HMSN. Okay, so peripheral nerves, if in case there's any confusion there, they're the ones that are found outside of the main central nervous system, so central nervous system, brain, and spinal cord. They control the muscles and relay sensory information, such as the sense of touch, from the limbs to the brain. Symptoms of Charcot-Marie Tooth disease, as we've already mentioned, there'll be muscle weakening in the feet, the ankles, and the legs at first. This is noticeable by an awkward gait that the patient will use, a high step gait. There's also maybe lack of sensation in the arms and feet, and very cold hands and feet or poor circulation is also quite common. In terms of treatment and management, it's focused around physiotherapy really, so helping them walk properly, walking aids, and it does get worse over time, so therefore regular assessment of the patient is really essential in ensuring that they have the best quality of life possible. Moving onwards, we have Guillain-Barre syndrome, which is rapid onset of muscle weakness caused by the immune system damaging the peripheral nervous system. The underlying mechanism is an autoimmune disorder, but the true cause of this syndrome is unknown. It's often referred to also as AIDP, so don't miss that. Acute inflammatory demyelinating polyneuropathy, which is quite a logical name for it, so it's quite an easy way to understand what this syndrome is doing to the body. In terms of treatment and management, most people will actually make a full recovery from this syndrome. However, it can occasionally be life-threatening. Long-term problems as well can also be caused by this condition. So intravenous immunoglobulin. So this is a treatment from donated blood that contains healthy antibodies. And this is rather logical because this is a condition which involves the immune system, and therefore treating the patient with healthy antibodies is a really good step in terms of preventing that damage of the nerves. Also, plasma exchange is really important. It's sometimes used instead of intravenous immunoglobulin, and this involves being attached to a machine that removes blood from a vein and filters the harmful antibodies out and keep the useful antibodies in. However, this is slightly more invasive for the patient and slightly more time consuming, so you'd have to consider which is the best option for the patient. Causes of Guillain-Barre syndrome are infections, particularly, normally. So 2/3 of the time it occurs a few days or weeks after an infection. The infection could be anything from food poisoning, flu, or even more rare viruses such as the Zika virus. Other triggers as well, so surgery and injury. So you're kind of thinking of anything that could cause some kind of infection, okay, is likely to increase your chance of suffering from Guillain-Barre syndrome. Next, you have motor neuron disease. Now, I'm not going to spend too long on this because I've already talked about ALS, and motor neuron disease is really more of an umbrella term covering ALS. Really, so ALS is one you need to know about, but there are also types of motor neuron disease such as HSP, PLS, PMA, etc., but you do not need to know about those, just ALS. What's really worth noting here is that motor neuron disease affects both upper motor neurons and lower motor neurons. So that makes it a little bit more difficult to spot in a clinical environment because you may exhibit features of both an upper motor neuron disease and a lower motor neuron disease. So symptoms in general, then we're thinking about a weakened grip, okay, and weakness at the shoulders that makes lifting the arm difficult, a foot drop caused by weak ankle muscles. So really, the underlying theme here is a weakness of muscles due to nerve damage. Okay, so moving on, we can look at stroke. So stroke you can break down into the different types of stroke. Broadly speaking, you have an ischemic stroke, which is a lack of blood flow, or a hemorrhagic stroke, which is due to bleeding from a weakened artery. Both are covered on this slide, and it's definitely worth having a read through the information about both types of stroke, because stroke in general is the third most common cause of death, and therefore it's quite a common thing that you're going to see, especially if you're working in A&E departments or neuro wards. Essentially, when we think about the word stroke, we should be thinking about a deprivation of our brain cells from oxygen and nutrients. And risk factors for this include smoking or excessive alcohol, high blood pressure, so hypertension, obesity, and high cholesterol levels. Also ataxia and apraxia. So ataxia is concerned with the cerebellum and is a disorder of coordination, balance, and speech. The different forms of ataxia can be broken down into central and sensory ataxia. So central ataxia is a problem with the cerebellar processing, and the sensory ataxia is a problem with the input into the cerebellum. Apraxia is a difficulty in planning the movements or selecting the correct movement in which you wish to perform. There are different types of apraxia, so this can be broken down even further. So ideomotor, limb kinetic apraxia, and constructional. It's really essential to only know a small amount of detail about each of those, but knowing about ataxia and apraxia as broad headings is what is really important here. Moving on, you've got multifocal neuronal neuropathy, and this is a disease that affects the body's motor nerves. It's a condition causing weakness but without the loss of sensation, and it progressively worsens over time. In a hospital scenario, sometimes it's mistaken for ALS if fasciculations are present. The cause is unknown, but it is an autoimmune disease, so it's similar to ALS in the respect that it's an autoimmune disease, and your immune system is mistakenly attacking your nerve cells. And current research is undergoing to try and find out what's really truly the cause of multifocal motor neuropathy. In terms of the symptoms, it usually isn't painful for the patient. It just causes a significant weakness without that loss of sensation, as we said. The first symptoms tend to be in the hands and lower arms and can kind of work its way around your body in terms of affecting different muscles. Usually the symptoms are more severe on one side of your body than the other, and eventually it may progress down into your legs also. And finally, for this video, we're going to look at double vision, which is also called diplopia, and it's basically seeing two images of a single object, and these two images may be at the side of each other or on top of each other or a mix of both. Now, what's really interesting about double vision is it sometimes can be constant in some patients, and in others it can be intermittent. But double vision is more of a symptom, I would say, of other diseases. It's not necessarily a disease in itself. Obviously, you can diagnose double vision in the respect that it could be in both eyes, one eye, and the patient will have symptoms in case of seeing double, for example. However, you'll find that double vision fits into a lot of illnesses and diseases related to the eye and the neurosensory system. In terms of treatment and management of this, there's quite a few roads to go down depending on the type of double vision you have, whether it's in one eye, monocular, or both eyes, binocular, and it also depends slightly on the cause. So surgery can help if you're having to squint in order to see things, but also there's options such as astigmatism, cataracts, and prisms. Okay, so that's all for part 3. There's one part remaining, part 4, where we'll cover the remaining 9 cases that we were taught about in the neuro block. Again, I hope this video has been useful to you, whether that be for hospital placement or exam revision or whatever. If you do have any feedback or any questions, as always, please leave them below in the comments or feel free to message me personally. Thank you very much for listening.